In this presentation, we're going to take a look at some examples of abnormal oral mucosa through the VELscope. We'll use what we've learned from the earlier modules and try to make sense of not only what we see with fluorescence visualization through the VELscope, but also how it relates to what we observe under white light. As we move on to considering genuinely abnormal mucosa, we should remind ourselves of some general principles. Evaluation of a suspicious area should generally be made in comparison to the contralateral side. Areas that show an irregularly shaped but relatively well delineated reduction of normal green fluorescence compared to surrounding tissue of the same type and to the equivalent location on the contralateral side should be watched carefully. Also, be on the alert for fluorescence patterns that appear to be out of context or unexplainable. When you see something under fluorescence that you really didn't expect to see, based on what you saw under white light, a good question to ask is always why. This should generally invite some further investigation of the area. Finally, abnormal patterns, whether they be under white light or under fluorescence that spread across different anatomical structures, should be investigated closely. This is a very simple example of bilateral presentation. The dark area on the right-hand side of the mouth has an equivalent dark area on the left-hand side. Of course, we've already discussed that the anterior tonsillar pillars typically appear dark under VELscope because of vascularity. But even if you didn't know this, the contralateral symmetry is generally a good sign that this is not a manifestation of disease, just normal anatomy. Blanching a lesion using diascopy has been a differential diagnosis technique in assessing oral lesions for a number of years. It involves compressing the tissue with a tool to locally empty blood vessels and thus reveal the vascular nature of a particular lesion. Inflammation, which involves intact, dilated blood vessels, will typically blanch. Due to the high contrast under fluorescence visualization, using an instrument to blanch a dark area under VELscope can be a useful technique for indicating whether or not an abnormality has an inflammatory component. Let's take a look at this example. This particular area blanches completely. Treatment and subsequent follow-up after 2 weeks resulted in complete resolution. The fact that tissue doesn't blanch is not necessarily a bad sign. Here is an example of some dark areas on the side of the tongue that did not blanch. It turned out that this particular abnormality was an ecchymosis, a type of soft tissue hemorrhage. When the patient showed up for the standard 2-week follow-up visit, the situation had resolved and the dark areas were gone. It should not be surprising that we might have trouble trying to blanch an ecchymosis if we stop to remember that for a soft tissue hemorrhage there has been vessel damage and blood has spilled out into the surrounding connective tissue. This makes it more difficult to blanch because the blood is no longer inside the blood vessels. The dilated blood vessels that occur as a result of inflammation can easily be blanched because the blood is still inside the blood vessels. This is an amalgam tattoo, a type of pigmented lesion. Given our discussion about how and why blanching occurs, it should be quite clear that a pigmented lesion will not blanch. The pigmented material does not reside, like the blood, in the vasculatory system where it's mobile. Thus, it cannot be moved out of the way using diascopic pressure. Using diascopic pressure to try and uncover the vascular or non-vascular nature of a particular area is, however, a subtle tool that must be used with care. Remember, we saw that one of the responses of the body to dysplastic growth can be inflammation. Our expectation for a dysplastic or cancerous area with inflammation should be that the parts of the lesion may blanch, inflammation, and parts associated with intrinsic loss due to dysplasia or cancer will not. Here is an example where an area of severe dysplasia shows evidence of blanching in perhaps the most clinically obvious area. See the picture on the lower right. The clinician from the University of Washington who performed this exam told me careful use of the blanching showed some areas of residual loss of fluorescence. The lesson is, blanching usually indicates an inflammatory component to what you're looking at, but it doesn't necessarily mean that it's an inflammatory lesion. This is a brief movie of a lesion which, as it turns out, shows loss of fluorescence from both dysplastic and inflammatory effects. Notice the general abnormal fluorescence pattern showing extensive areas of loss of fluorescence. This is the same patient as in the previous movie. Initially, we're seeing the other side of the tongue, which has a completely normal fluorescence pattern. Watch closely as the patient moves their tongue so that we can see the other side of the lesion. Notice that the anterior part of the lesion starts out showing no loss of fluorescence and quickly becomes dark as the blood rushes in and fills the blood vessels. Let's take a look at that again. Did you see it? This area of the lesion would undoubtedly have blanched under diastolic pressure. It's a good example of how inflammation and dysplasia and/or cancer can coexist in a lesion, and both can give rise to a loss of fluorescence. In this slide you can see a rather subtle area of redness or erythema that did not blanch under compression when the corresponding dark area was blanched under fluorescence. This area was found to contain dysplasia when biopsied. In this movie, there is evidence of blanching in some areas, but it's also quite clear that this lesion does not completely blanch, especially around the anterior part of the lesion. This lesion was found to contain dysplastic tissue. So here are some important things to remember about blanching. Blanching can indicate that an abnormality has an inflammatory component. Soft tissue hemorrhages, such as an ecchymosis, may not blanch. Pigmented lesions are not going to blanch. Although we might expect a precancerous or cancerous lesion not to blanch because of the associated intrinsic loss of fluorescence, as explained earlier, we must remember that cancerous or precancerous lesions typically have associated inflammation. Therefore, they may partially blanch. However, the bottom line is that not only should an abnormality that does not completely blanch under VELscope be carefully followed, so as to determine its cause and/or rule out dysplasia or oral cancer, but also an abnormality that does completely blanch but persists is of equal concern. And this is a very, very important point.